You've been told high cholesterol is dangerous and statins are the answer. But is that the full story? Today, we break down the truth about cholesterol, statins, and heart health so you can make the most informed decisions right here on WellWave Now. Welcome to WellWave Now, your portal to actionable wellness insights. We, Breck Rice, Dr. Bob Levine, and me, Tim Daniels, are your wellness catalysts committed to elevating your health, enhancing your functionality, and optimizing your performance at every life stage. WellWave Now, where timeless wisdom lights your wellness path. Today, we are welcoming back as a fantastic guest co-host, Mary Yuter, RN. She's a cardiac ICU nurse who transitioned into rehabilitative and preventive wellness and has become an expert in that area, especially in preventing and reversing heart disease. She is the founder of Heart to Soul Cardiac Wellness. We are tackling today one of the most prescribed drugs of the world, that's statins. You have heard they lower cholesterol, but is cholesterol really the villain? What does it actually do in the body? Are statins truly effective, or are they just a symptom-based fix? What are the risks and what are the alternatives? This is a roundtable discussion where we'll share opinions, insights, and personal perspectives on the pros, cons, uses, and misuses of statins. Let's get into it. Before we talk about statins, we really have to understand cholesterols and talk about them a little bit. Most people think of cholesterol as an enemy, but let's look at what it actually does in the body. So, Mary, why don't you take that a little bit for us, if you would?
Okay, Tim, thanks for that great introduction. And it's a pleasure to be back, as always, to chomp it up with you guys. So, yeah, statins. So, as a cardiac ICU nurse, I just saw an algorithm going on of if this, then this. And the current algorithm is if a person's cholesterol is 200 or greater, they get a statin now. And it used to be 300, it dropped to 250, then it dropped to under 199. And mind you, most people have their first heart attack with normal range cholesterol. So let's talk about statins in the body. First of all, our bodies are so smart. They know how to shuttle around the cholesterol. They know when to bring it back into the liver and when the liver should send out a little package to patch up a problem. So it's endogenously made, meaning the body can make it, and then it's exogenously brought in by foods that we eat. But again, our bodies know what to do with it and if they need it. So how do we use cholesterol? What's going on with it? Well, numero uno is the importance of cholesterol in the brain. The brain is the organ that needs cholesterol the most in the body. And why is that? Because the brain is made up 25% of cholesterol. Breast milk is made up of a high cholesterol content for a baby's brain development. The myelin sheaths that surround the nerves are wrapped in cholesterol. So cholesterol is very, very important for our brain health.
Oh, well, hold on just a second, Mary.
Okay.
Because, well, one thing, you mentioned the myelin sheath. So what is this myelin sheath and why is it important?
It is a wrapping around the nerves, and it helps to conduct synapse to synapse are chemical neurotransmitters. So, for example, copper is a good conductor. It's like lacking copper in an electrical fixture. Okay, so it helps our synapses.
That helps me, Mary. You remember?
It helps our memory.
Yeah, but I just had a fifth grade education, so you gotta break it down to me. So it's like a fifth grade education.
It's okay. That's why we're talking about this.
That coming from the graduate of Stanford. So anyway, hey, but to actually pare it down for some of our listeners, we've always heard about the good cholesterol and the bad cholesterol, and there's that, what is it, the HDL and the LDL? Get into that a little bit for our listeners as well.
Okay, so we actually have HDL, which is considered the good cholesterol, and LDL considered the bad cholesterol. There's a type of LDL called VLDL, very low density lipoprotein. And we also have triglycerides, which are not in the mix, but are very important because they're shuttled around, they turn into fat and they're shuttled around with VLDLs. So the LDL has been told that we've been told that it's the bad cholesterol. It's really coming in to patch up a hole in the arteries or damage to the arterial wall, whether that be from inflammation, whether it be from high blood pressure, hypertension, or whether it be from damage from these hard, caramelized, if you will, oxygenated, or what do you call it? What is the word I'm using for when it's rusty? oxidized
Oxidized, yeah,
VLDL proteins.
oxidation.
That can hurt the artery wall. The cholesterol comes in and says, hey, I got to patch up this problem. Cholesterol's not the bad guy. It's sent by the body to patch up this problem, but it has been misnomered through history, starting with a gentleman named Ansel Keys, which we can get into later.
No, dive in a little bit to that.
Okay.
Because people are like Breck says, we hear the HDL and the LDL, and the LDL is always bad, and they will look at the ratio sometimes. But your studies and thinking and knowledge is saying something different here. I think that's important.
It's saying something different than the traditional allopathic world and what I was trained in as a bedside nurse. So to continue, LDL is not the bad. It's a repair mechanism for a problem. Okay. The VLDL is a problem because that's a cholesterol that has been hanging out there that got caramelized and oxidized, and it is now the problematic cholesterol that can get in under the artery wall and start that plaque and foam cell and creating this cap, this hard cap. And then we have the HDL, which is considered our good cholesterol. And that is the cholesterol that comes by and says, let me take all this extra stuff that's floating around the bloodstream, bring it back to the liver for reprocessing and packaging and use again. So the HDL is very important to have a high level, and triglycerides, which go along with the VLDL, is a low level. Those are the two things to really be keeping in mind, not all this other mishiganess. So what we want to do as a barometer for looking at our cardiovascular health and risk is look at the triglyceride level and compare it to our HDL. If you have a higher than 2, meaning for every one of these triglyceride VLDLs, if you have more than 2 of those per 1 HDL, that's not good, because the HDL is going to take them back into the liver. If you've got a 5-to-1 ratio, that's not good. That means you got a lot of stuff out there that's going to turn into fat and cholesterol and plaque, right? And cholesterol is also how we make our hormones. And what is one of our hormones? Insulin, our sex hormones, vitamin D, which is actually not a vitamin, it's a hormone. So it also, cholesterol is also important for our cell membranes, specifically the fatty lipid layer on the outside of each membrane. And that allows us to receive our fat-soluble vitamins A, D, which is a hormone, E, and K. If you are supplementing only with vitamin D without K2, you are going to put calcium straight into your arteries. And what did I see and what did I give many times bedside without knowing this? As prescribed, doctor's orders, straight up vitamin D. So you're continuing the cardiac process there by having someone straight on vitamin D. You must have D3 with K2 to put the calcium in your bones and teeth. Otherwise, it'll go straight to the arteries without K2. Now
hold on just a second, though.
Yeah.
Just 1 second on that, because that is a tremendous combination. I take it personally myself. Dr. Bob probably knew this already, and Tim's super smart, and he knew this probably already, but I didn't. I learned from one of our guests that you have to take that supplement also with something that has a little fat in it to actually absorb it correctly.
Correct.
Okay.
Yeah,
so you can't just take it by itself. You have to eat a small meal or something and then take that supplement.
Yeah, something with a little fat in it. Even nuts, like if you have your daily Brazil nuts or some walnuts, that'll help to absorb it. Yeah, okay. Very good point. So
Dr. Bob, you better talk to Dr. Bob. Dr. Bob doesn't eat fat. He just eats lean,
Yeah.
Okay, I unmuted myself. I had to defend myself, Tim. No, actually, I'm closer to a paleo than anything else. So I'm a fat protein type of person with tons of vegetables.
Yeah.
So that's what Dr. Mark Hyman calls paleo vegan.
Okay.
Which I like, where you kind of make your meat a side dish. So it's got the amount as a side dish, but it's what we've been told about cholesterol being the bad guy and stay away from red meat and all that. That's not true. We need the fats. We need all the nutrients. I was hardcore vegan for 5 years, and while I felt okay, there were signs in my body that I was deficient in things, and I started eating really good quality, grass-fed, grass-finished, non-injected, healthy meat from where I moved upstate New York, and it's made quite a difference. But to continue on, there's a couple more points
one
here.
more thing. One more thing is my understanding is the body makes like 95% of the cholesterol that it uses, and the rest comes from maybe diet. So diet is a really tiny influence on the cholesterol levels in the body. Is that accurate?
Yeah, the body, like I said, the body takes care of the levels it needs. It takes care of the levels that your body wants. And this taking away cholesterol because of a statin, first of all, if you're lowering the range where you give a statin, and you're lowering the blood pressure range where you give blood pressure meds, that increases sales, right? This is not about
Totally.
health. This is about sales.
Yeah. So Mary, what was, if you recall or know, just came to mind here, what was the stated now? So we've got sometimes it's tough living with all you. I got three you conspiracy people here on the screen with me. Sometimes it's tough being the voice of reason here, but
what?
Bob would say
Tim, you're the self-appointed voice of reason here.
There you go. I was about to say, Bob would say you're the one that's blind, and we're trying to open up your aperture so you can see the truth here. But
one thing that's not a conspiracy theory, Tim, and then I'm going to let you roll.
No. But let me ask this question to Mary. Then you can come back and say it's not a conspiracy theory. But where you say so we talked about the potential motivation of people of lowering. Why they lowered that level where statins should be applied, but and that that can spark some thoughts. People to really check it out. But I think also if you recall or remember, what was the stated reason? What was the rationale given out there to the public to say, okay, it's no longer 300. It really should be 250. Why? What was driving that?
Well, this is a poor rationale, and it's a blanket for everybody. And remember, cholesterol is there for a reason to help. If you start to think critical thinkers, if we start to remove cholesterol and the brain needs it, what disease process is now rampant dealing with the brain?
Yeah,
Alzheimer's, dementia. Okay, that's number one. Number two, most heart attacks start with regular normal range cholesterol. Most heart attacks.
Right.
Number
so now
three.
Go with your number three. Go ahead.
Number three, if we're missing vitamin D from our system, we have an increase in cancer, the second largest problem in our healthcare system. And they're prescribing this when there's no need for it.
So let's come back to that, and I promised Dr. Bob I'd let him make his comment after I stuck the needle in him. I got to let Bob respond. But what if somebody came to you, Mary, and they've got a level of 400 in cholesterol? What is it then? What are you saying then? Is that, does the body need that level? That's what's happening, or is something? Or would you say something's off that we got to address, whether it's lifestyle or something else? What would you say then?
Well, you would not look at that little piece in a vacuum. You have to look at what are their hormone levels? What else is going on for them? What are the other lipid markers? What do their triglycerides look like? Some people, they may actually need that. Maybe they have something going on in their brain, and their brain needs more fat, more cholesterol. Maybe something happened. Maybe they have some kind of disease process elsewhere where that's going to be shuttled to it. But we can't look at one value, and that's the problem, is the Western medical system looks at, okay, what's that? And when really, what's your triglycerides looking at? Oh, they're low. What's your HDL? Oh, that's high. What are your VLDLs? Low? Well, that's great. Maybe the person's going to be launching into Parkinson's, and this is a protective mechanism by the body. So we have to look at the whole big picture and the medical history behind it. 400 might be perfect. Or is their LP little a high? Do they have a genetic component there that's driving this up? Some cases, if there are other things going on, perhaps a statin might be needed, but I really hesitate to say that that's the case if their coronary arteries look good, if everything's looking good.
Is that a genetic marker?
Hold on, Breck, if you would, because Dr. Bob will never forgive me if I don't let him come up and state what he wanted to state earlier. So go ahead, Dr. Bob.
I don't even remember. I think I need some vitamin D and K to help my memory. I'm just joking around. One thing is an anecdote. I wanted to say that my mother had a cholesterol level of over 300 her whole life, and she refused to take statins, and they recommended her take statins. She said, no way. And she had no problems cardiovascularly. She lived to 84. She unfortunately died of lung cancer because she was a smoker of about 50 some years. And that bit her, but her cholesterol was not a big deal. And so I think you're absolutely right when you say you got to look at all the markers. And it just points to our conventional medical system is so isolated. Everybody's a specialist. Everybody looks at their little piece, and that's it. No, and less people are looking at the whole, the integrative whole. So, and also, I'm not sure. The other thing I want to say is that low cholesterol diets are ruinous, I think, for our country because, it was a bandwagon. Low cholesterol was one of the bandwagons. Low fat was one of the other bandwagons. Those two together were ruinous, I think, for our overall health. And I don't think the evidence is that great that the statins are wonderful for. I think it's been shown that they actually don't reduce heart attacks. If I'm correct, is that right?
Yes.
Well, there's some counters to that, which says that like Mary talked to that if and in some cases, like if someone already has heart disease and this is a secondary thing, there's some of that evidence to show that lowering the statins has decreased it to them. There's studies out there on that.
With every medication, there's risk versus benefits, and if
yes, we know that. We'll get into that, and Breck's going to talk about it a little bit. But the other thing I do want to say, I'm going to defend the primary care doctors that I've had, and I think it's important. I select mine for a good number of years. For the past 20 years, I look at them: are they integrative? I want to know their background. I really spend time understanding who my primary care is going to be. Now, how do I tie that into this? We looked at my cholesterol a couple times, and she, to her credit, looked at it and said, went almost what we looked at. Said, well, one, we're gonna take a look at your C-reactive protein, which is a measure of inflammation in the body. And she said, we're going to use the heart sensitive one to see if there's anything going on here. When we're going to look at this, we're going to look at a couple other things on there. So she balanced it out. And she said, we could even do something that I think it's a CT scan of the heart to look at things like that. We didn't do it that time, but I had to do a CT scan later on for something else. And we looked at, covered the chest, look at that. She said, you're fine. My cholesterol was not way off. So basically she said the same, what we're talking about here. Said, yours are fine for where you're at. You have no inflammation in the body. There's no calcification around these arteries. You don't need to be doing anything. So I think, so I think there may be some who aren't like Mary. She's trained herself and taught herself, and certain research out there. I think there are good MDs out there as well that will look and balance across the board and not rush to statins or any drugs. And I think it behooves everybody to spend time understanding that with their primary care. What are they about? What's their philosophy? What's their level of knowledge? And choose as best you can who's going to be your providers.
That's really good, Tim. Yeah, thank you, Tim. And I'm just going to jump in real quick to say that that what we're talking about here is a pretty simple bits of information that every person could have, and when they know these little pieces, they don't have to know all the details, and then they go into their doctor and say, tell me why I should be doing this, and what do you know about all these different pieces, and see what the doctor knows. And unfortunately, a lot of them can't really talk about all the little pieces.
Right. And now I do say as part of that, even with my primary this time, we talked about the C-reactive protein, and I mentioned C-reactive protein, and then she said, okay, fine, but I'm also going to do the heat sensitive, the highly sensitive one, also called the cardiac one. But it's as we've talked to our audience about, and people, it is good, like Bob said, to educate yourself, because she said, I normally don't offer these up in general cases because insurance doesn't pay for it, but it's something that didn't cost much. It didn't add much to the code, and you can look at those tests, and I encourage everybody to look at their tests and then have that conversation with them. You talk about like triglycerides, what you just said, Mary. Well, we take a look, and my triglycerides are all right, but have that conversation between, what does this really mean? You look at this, it says fine. Why do you look at that? And I actually, when I get my blood tests, or I still have to do it every year because I can't remember what all the stuff about, but I will go out and I will look at each one of the things on that blood test and say, what is it supposed to tell me? And I prepare for that conversation when I review that with my primary on that. All right, so there's my commercial. Breck will give us a promo later on, but go ahead, Mary. Back to you.
Well, I think those are great points, and it is important. We don't want to be vigilantes. It's very important to have our doctor as our partner in our care. But if you're looking at your doctor and they're overweight and they're talking about themselves being on statin, it might be prudent to look for a different doctor. And again, you want to look for the whole, like, hormones. Hormones are being impacted. If you don't have enough cholesterol, you're not going to have the proper hormones. You're not going to have vitamin D. So I know that if we impinge the body's ability to process cholesterol, Breck is going to take that away. And it's really important. And if you think about the things I was talking about, the reasons we have cholesterol in the body, and then you think about, wow, if you take that away, what's going to happen? It's pretty critical. And the amount of people that are being impacted by taking statins and all the different side effects it's really, really bad. And also, to Dr. Bob's point, by this information that we're supposed to keep a low cholesterol, low fat, low salt diet, our country has never been sicker. We spend the most as any country on healthcare, and we're something like in the 30th or 37th ranking in world health. So there's something wrong here, and this is the biggest part. Is heart disease is number one. It's reversible and preventable, and so is type 2 diabetes.
Yeah.
Yeah, one more quickie point is that, we have this obesity epidemic, and what is it? 70% of the country is either overweight or obese, and what percentage of those people are on statins? One of the things we know about the lipid profile is that the mildest of exercise has a monstrous impact, positive impact on the lipid profile. Raising HDLs and lowering LDLs and lowering cholesterol levels, and I've done it myself. In my life, and seeing how much exercise has impacted that. And so, are the doctors helping these people with the obese problems? Are they helping them, or are they just giving them statins? What's going on here? Anyway, that's enough of that.
That's an excellent point. And diabetes leads to heart disease. So it's like the feeder to heart disease. And what we're doing is we're giving people metformin, moving them onto insulin, and it's totally a negative feedback. Keep it going. And
go ahead.
Insulin resistance is the biggest problem, and that's
huge.
Yeah, we're eating too many processed foods and too much sugar, and that's creating those triglycerides and the VLDLs, and then your body just stops listening, and you've got all this sugar, and that leads to the diabetes. And it's reversible, it's preventable. You can still have your meat, you can still have a beautiful candy, but it's trimming down the bad stuff that's made in a plant and having more plants. Really, and exercising your biggest muscles in your body, your quads and your glutes. Those are sinks for insulin and glucose. You're going to take that out of your system in an easier way. So even walking, like Dr. Bob was doing, or squats after a meal, if you can't get out in the snow, perfect to help.
Yeah, absolutely.
So there's three. And we move on. And so there's three. You just hit on three of our podcasts that people should go listen to. Yep. One, your own, Mary, that talk about preventing, reversing heart disease. Number two, people should look at something from that has a Dr. George Grant on that. And I don't recall the name of that one on, but that talked about diabetes and how do you prevent and reverse diabetes correctly. And then we had another one that's exercise as medicine and what that could do for the body. And I know we're also going to do a part 2 to this that will reemphasize what you can do to mitigate the CV risk, cardiovascular risk, and prevent it and mitigate it if you do have the disease. But as we get into that, we've covered a lot of ground here so far. I want to recap a little bit and then ask Breck a question. So one, we said, cholesterol is good. The body needs it for brains, needs it for hormones and other things. We said it's, a simple, and LDL in and of itself has gotten a little bit of a bad reputation because it serves a purpose as well. And so you really want to look, and then also, so you want to make sure, look at the balance of things in the body of the HDL, whether it's cholesterol or triglycerides, with the level of inflammation in the body and other things. Okay. Now let's say somebody says, okay, or they said, I'm going to put you on, right. They see cholesterol is, they don't understand or something that a 350 cholesterol might be good. So what the body needs, I'm going to put you on a statin to lower it. Question becomes, so how does Breck, how does that because you're the scary drug fat guy. We often forget that when you with your other realm and wealth of knowledge, but you are known as the scary drug fat guy. So tell us what you see, how you see statins work, and Mary alluded to some of the things before that once you lower that or stop some production of that, some of the side effects you see out there with statins, right?
Yeah, and first we should cover something that Dr. Bob studied for 20 years, with the health system, the big, huge health system he was with and doing brain research there. And that's the efficacy of all those millions of patients that are on any given medication, especially statins, right? What benefit is that those several million people on the statins actually getting? Are they actually metabolizing that medication? So it's interesting to look at those statistics, right? Too, the manufacturer makes a product, a medication to to be available to the entire population, but yet what? Only 30 to 50% are actually getting the intended benefit. So you could literally have up to 70% of the patient population on a medication that isn't even getting the intended benefit, but yet they're still getting all of the negative side effects. And so that's why I always say, if the benefits are there, great. But if the side effects outweigh those benefits, you've got to do something different, right?
Yeah.
So
absolutely.
if you want me to get into the specific side effects of statins, I'm happy to do that, because like all medications, statins have some side effects, and let's discuss some of the common ones. Most common complaint from patients is muscle pain. The most common complaint on being on a statin is muscle pain and muscle weakness. There's digestive issues that go along with the medication, like nausea, constipation, diarrhea, just general indigestion, headaches. Go ahead, Tim.
One close second that I think you mentioned that. Now, I think those are very important side effects, and I think, but I also want to tie that back a little bit to Mary's comment about why these happen, and why partially that happens. That could be directly of the drug itself potentially, and I want to lean on you for that. But the other way, as I understand it, and both of you might be able to correct me on this if I'm incorrect, is that the way statins work is because they actually stop the liver from producing the cholesterol. So when you stop that production of the cholesterol, it ties back into some of the things that Mary talked about, why your body needs that cholesterol. And I hate to say it because, Mary's head's so big anyway, that I don't want to make her head bigger. She educated me today that your body produces the amount you need. So if you're taking that away, then it rolls into these side effects you're talking about. So please continue though, Breck.
Well, yeah. I mean, now since you sidebarred us, let's go back 3 episodes. Please listen to my own personal experience on a medication that was literally stopping the digestive acids to do their job. Right? I was taking a PPI so that I would not have reflux, but then
proton pump inhibitor, right?
Exactly. Yes. Yeah. And that medication was beautiful for the GERD or the reflux, but it wasn't good for my digestive because it was literally shutting down those secretions that are needed to digest food properly. Besides the fact that it leached all of the bone density out of my ankle, and I blew that up on the ski slope, right? So you'll have to go listen to that episode. But let's continue on with the digestive issues, the headache, sleep disturbances is another common complaint. So insomnia, or even patients complain of unusual dreams, dizziness, especially when first starting the medication. Now, on the less common and more serious side effects, you can actually damage your muscles being on a statin. Liver damage. A lot of medications have that, right? Because you're putting a synthetic into your body that your liver is trying to process. So there can be some damage there. Increased blood sugar. Type 2 diabetes from a medication? That's it's less common, but it's certainly scary.
Remember, we're interfering with hormone production.
Yep.
Yeah. The other thing I wanted to point out on your very important point is damaging the muscles can create rhabdomyolysis, and that's a breakdown of muscle tissue, which can damage your kidneys.
Yep. That is actually one of the side effects that I had listed as well. So thank you for covering that. Memory loss and confusion is another issue. Allergic reactions. There's a certain percentage of patients that are going to actually react negatively to the medication, which can cause rashes, have itchiness, swelling. The swelling happens usually in the face, tongue, or throat, so you feel like your throat's closing up. And as you mentioned, Mary, the actual permanent damage. There's even a rare autoimmune condition that causes a permanent weakness to the muscle as well. So, like any medication, measure the benefits versus the side effects.
Just one more point here I would like to put in is it's really important for people to understand that the expression of a symptom usually has many factors that feed into the expression of the symptom. So when you put a drug on board and the drug is causing the quote side effect, there's all these other factors that are feeding in. So it's not necessarily just the drug, unfortunately. And Tim, you'll think I'm talking on your side of the fence here. The drug has an input, but all these other things, especially stress plus a drug, everything that's going on in life has an impact on the expression of a symptom. So it could be that a drug side effect could be caused by all these other factors that are feeding into somebody's life. And so it's important to understand that every condition, every symptom usually has many factors that feed in, including drug side effects, including stress, including everything else.
Dr. Bob, including another prescription medication.
Yeah, totally. Yeah, absolutely. Yeah.
Yeah,
wanted to make that point.
These side effects are actually a toxic response to the body. And now we're giving another a wet blanket over a fire that the fire's still, it's not out. It's just continuing. So drugs are like putting duct tape over the check engine light on your car. The problem's still there. You just covered up the warning light. And that's what this is it's disease maintenance and symptom management.
Yeah. So it's a very, very important, very good point, Mary. The other thing, Bob, I think Breck prompted you down that path where you go sometimes. I think is good to reiterate, which is when you talk about people the companies pharmaceutical. Now I'm going to sound like I'm over on your side of the fence, but pharmaceutical companies they do all their testing on the one drug and they give you what the side effects are of that. But what happens, Bob, when you add you're taking that with another drug? Go through your thinking on that.
Well, I always make the point that when a drug company does a drug trial, first of all, people want to understand that the less effective a drug is at a targeted to produce a targeted effect, the less effective the drug is, the more subjects you need, the more people you need to test it. So if you have a really good intervention, it's highly effective. Maybe you need 20 people in a clinical study because if you have 12 or 14 people that are completely alleviated the problem with the clinical study, that's going to be wildly statistically significant. It's a fantastic study. If you have a drug that's not that effective and has a lot of side effects and it's not much better than placebo, you need thousands of people in a study. So and the drug companies have a lot of money. They can afford to run these big clinical trials. They can have thousands of people running through, and they can get the drug producing a 10% effect above placebo, and they have a multi-billion-dollar drug. So that's one thing. But the other thing I want to say is, when drug companies test a drug, they don't test one drug with another drug with another drug. They test one drug in the population, and they use our normal population. Our normal population, the health of the normal population is not that great, as we know, based on our international status of poor health in this country. Even though, as Mary pointed out, we spend more money than anybody in the world on healthcare. So they test one drug at a time. But in reality, I beg you to find a person who's taking only one drug rather than taking 2 or 3 or 4. And those are never tested together. So as soon as you take drug A, which was tested, you add drug B, which was not tested with A, and C, which was not tested with A. You have A, B, and C together. That is basically not evidence-based medicine anymore. It's just guinea pig studies, and the side effects on top of side effects. And that's why a lot of the clients I deal with, being a PhD, I don't deal with, and I have a PhD in pharmacology, so I can advise people a lot how to talk to the doctor about getting off their drugs if it's appropriate. And the physician should be running that side of the fence. But all of the clients I deal with that are in the neighborhood of 40 to 90, my oldest client is 99, they're all on at least one drug. It's just wild. And usually 2, 3, 4. I mean, I just had a client, 78 years old, pretty decent shape, a lot of chronic pain, but he's got 10 drug bottles on the side of his bed. It's like, wow, it's wild. I'll stop there.
Okay.
Yeah,
Yeah,
well, I
that's
always
why.
say that the first one or two medications are actually treating a symptom, right? But then medication 3 and 4 are counteracting the side effects of 1 and 2 and so on.
I
Right.
will articulate to what I do in my home care days. It really that really a lot of I think it's the average person over 50 is on five to seven drugs. And it really became incumbent upon, the nurses that I, had that were in my world, reaching back out to the primary care doctors or sometimes the pharmacists to really at that, it's so that drug interaction and what happens and are they interacting with each other and should this be taken with that? From my experience, that really became an on the ground analysis between in the home care world between the nurse, the doctor, and sometimes the pharmacist to really see what are these interactions really happening in many cases on that based upon their knowledge was what's happening. Go ahead, Mary.
Can I ask a question, guys? Maybe Dr. Bob could handle this one. And I think this is important for our listeners to hear. And I would love some clarification too, because it always gets muddled. But the relative versus the absolute reporting of drug efficacy in a trial. So they report it's a matter of semantics on the way that they're reporting. In one way, biases the reporting to look better. So it's how many people needed to treat, and maybe we can table that for another conversation, and we could talk about that more.
It's a whole world of clinical trials. It's a whole world of I'm just going to use the word voodoo kind of in a way because the people who run clinical trials often figure out ways of leaving data out. Oh, that data should not be in this data set. But that's not the way appropriate clinical trials are run. Like when I ran all the clinical trials showing the alternative non-insurance covered modalities that I treat people with that are non-pharmacological. The clinical studies I did, if somebody dropped out of the study, we had to include them. So, and a lot of people don't do that. So the people who run clinical trials sometimes are very clever about how they eliminate data. And that's probably the biggest issue, or just withholding clinical data or not reporting the data whatsoever. Oh, that's a bad study. We're not going to report that. So.
Yeah, first day of MBA school, walk into my stats class, everybody complains about having to take stats, and professor gets up and he said, "What's another terminology for a statistician?" We're all like, he's a damn liar. So he basically went into the whole strategy of how you even set up the sampling to get the results you're looking for. Yeah,
that's right. That's a huge problem. I mean, when you test a hypothesis, you're testing it yes or you're testing it no. So it doesn't matter how you state it, but the thing is, the way you test it has to be able to answer the question appropriately and morally and effectively, let's say. So yeah, you're absolutely right, Breck. And the statisticians, they sort of ask you, well, what do you want here? It's kind of a little bit crazy.
Now, unless they're, I was trained as a statistician. Part of that. So unless you're a University of Chicago statistician, and then we just purely look for the truth in the numbers. Okay, let me tie this all back. So part of this we were talking about, do you use this and study the efficacy of statins? And I saw Mary about to refute me. She can if she wants to. The only thing that I saw was that it was statins when it was if it was a secondary cause, someone already had heart disease, already suffered an incident, then yes, it was shown that it had reduced recurrence or another incidence. I saw
maybe that's confounded with someone cleaning up their life after a first event. Because as we discussed, most people had their first event with normal cholesterol. So
absolutely,
there's no need for this.
Now a good statistician would control for that variable of lifestyle. But I'm not going to say we don't know how it was done, how it was looked at, how the study was done. A good statistician will control for that variable. However, so I won't rule out that it could be the lifestyle changes. Now, however, though, so we've got that. I did see that in some older adults, and I wish this is tied back to the insulin thing. I wish I had known now what I didn't know then. When my father was in his 70s and diabetic, and some doctor says it's now time for you to start taking insulin when you hadn't before, and that's the worst thing you can do for somebody in their 70s. So like that, I understand that statins for older people can be even more detrimental and have not been shown to do anything. So I want to give two things, and we'll go back. So I want to give Breck the opportunity here. Since I have to moderate amongst all you guys, it is me giving the opportunities here. I want to give Breck the opportunity to see if he wants to add anything more about side effects and the causes and the ramifications of that. But after that, then Mary, we want to then go into, okay, could one do? We determined something's off. So what can someone do? As Breck often says, and they'll say, "Well, do the better if the side effects outweigh the benefits, it's time to do something different." So in this case, these side effects may outweigh the benefits. So what do we do a little bit differently here? But Breck, go ahead. Anything you want to say for anything else?
The only thing I would add to someone interested in lowering that LDL side, that there's evidence that I learned from Dr. Greger, reading, How Not to Die, the book that's so popular, especially with the vegan community, right? Because it's all plant-based diet. But there's a 50-year-old study that a handful of Brazil nuts will lower your bad cholesterol better than a statin, but there's just not a big lobbying group behind Brazil nuts to put that study out there for everybody to know about it. So you can't make billions of dollars off of Brazil nuts, evidently. A good thing too that patients can do now, and some insurances will cover that, and that's the pharmacogenomics test that you could go to any Brim wellness center, any pharmacy now these days, and ask for a pharmacogenomics, basically a genetic test that will identify what medications you can actually properly metabolize, because there's probably a good number of medications you're currently on that you're not getting those intended benefits. So check into pharmacogenomics testing, or a DNA test to see what medications work best with you.
Mentioned, we always like to give people little actionable things to do as part of our discussion, and you alluded to some earlier, and we're going to have a follow-up discussion on this. It really dives into how do you reverse and prevent and mitigate the cardiovascular disease and risk on that. But let's give folks a little bit now on what should they do.
Well, I would say first that we need to get blood work to see everything that's going on, and I have a blood work panel that I ask my clients to get so that we can go over everything. And what I can do is put that on my website for listeners so they can grab it. And that's the first step, is being an investigative reporter, and getting more knowledge. Hanging out with people like us is a great start as well. And I do have a spreadsheet that I'm compiling of all the different things, whether it be pomegranate juice to lower your diastolic, or like red yeast rice for lowering cholesterol. But again, is cholesterol really our problem, or is it inflammation? Is it something else that's causing the problem? So first, I want to start with the blood work. I think that's the most important area, rather than saying, let's do this, let's do that, because it's like we're our own personal chemistry sets, and it's like a teeter-totter. And if you're going to take something out of balance, something else is going to be affected. So first is looking at the big picture and seeing, what's going on here. So I can put that on my website for people to grab, and they can get those bloods.
And what's your website for the audio listeners, Mary?
My website is www.hearttosoulcw.com. So that's heart2soulcw.com. No numbers. And I'll get that on there in the next couple of days, and people can come and snatch that blood work. As you were saying, Tim, some of it may not be covered by insurance, but it's important, at least, and not hugely expensive, to get a nice baseline and a full picture. From there, or you can go with whatever you're able to get and afford. There's always, there's the basics, like the lipids, the inflammatory markers are very helpful, and the diabetes markers, fasting insulin, and your hormones. Those are all like really important and work together to give us a nice, clear picture of what might be going on. So I'd say that's the first step, and then we can talk about the LDL and what actually the real problem is insulin resistance. That's really what's causing the big problem here.
Right. And Breck, I think this is a good time to reiterate your point along with the blood testing, the other type of testing, the pharmacogenetic testing, that might be able to say what else that can do for you.
Yeah, absolutely. It not only tells you what medication you can actually metabolize or utilize, but it's a good measuring stick for which medications actually work together well, because not all of them do work together well. And so that's something you want to be aware of. And your pharmacists, your PharmDs are super smart. They know those interactions. And so now you have a science-based test based on your genetic makeup of what those interactions are. So there's certain medications that just can't be taken together. And unfortunately, the way that our system is set up, if you have a symptom, there's a pill for that. If you have a symptom, there's another pill for that. And you need to know that, hey, those two may not work together. And so you need to do something different.
Great. That's great.
Yep. So want to make sure that everybody also knows that they can join the Facebook group, the WellWaveNOW Facebook group, because that is a great resource for you too as well. We'll leave a link in the show notes for you. Mary has given her website as another resource. And then we're certainly looking forward to you returning back and doing part 2 with us, Mary, and what it really takes to prevent and even reverse or mitigate heart disease. That's so important. The work that you're doing is absolutely phenomenal, and we are happy to have you be a guest host with us again.
Thank you so much. I love it. I'm happy to help. It's my passion.